Breast Awareness Month. It is October. Of course, it should be Breast Awareness Month every month, and Dr. Blake can certainly fill us in on that. Our wonderful guest is Dr. Cassan Blake, who is she's actually a breast surgeon with Cleveland Clinic, and I'm so glad that she's going to talk to us today. You've probably heard her. She's done our show before, I think, and weren't you in our Cure Symposium? Yes, you were. I remember that. So, okay, well, this is the October month, and everybody is really thinking about their breasts more than they normally do. But don't you think it's good for people to think about it every month?
I do. I think that, it's important to be aware of your breast health. I think the month is just to raise awareness globally, but I think on an individual basis, we all need to be aware that, breast cancer can affect our family, affect our friends, but we also need to be mindful of our own breast health.
We have an article in this issue written by she's a psychologist and she works with women, and the title of her article is Hug Your Breasts.
Okay.
Hug your breasts, know your breasts and hug them and love them and so forth. But I think what I wanted to just ask you a question before we get started on a lot of the very technical things. There's interesting that some women have breast cancer and they go through, all the modalities and they seem to be fine. It could be 10 years, 20 years, 30 years. And others do the same thing and it's not fine.
Right.
What is the difference?
We're still learning a lot about breast cancer, and sometimes, people get the same exact treatment, but the biology of their tumor may be different. And sometimes there are factors that, as a physician, we may say, we're a little bit more worried. They're at higher risk for the cancer to spread later on, even though we're giving them awesome treatment. And then there are other people sometimes that, they have the kind of cancer, say, well, usually this cancer will behave well, so to speak. And unfortunately, sometimes the cancer can still spread. What I tell my patients is we know a lot about breast cancer, but there's so much more that we still just don't know. And that's why we continue to say we have to raise awareness. We have to do breast cancer walks. We have to have money for research, because we still don't have an answer for every scenario to know this is going to cure this person of breast cancer.
That's a very good answer, and thank you. And it's people always ask that. I know there was a woman who lived to be 101, and she had breast cancer in the early years. And there were no technical or no all the great medicine that we know today. She didn't have that, but somehow she survived.
Right.
She didn't have the mastectomy or anything. She just whatever they gave her. So a lot of people. Let's get into the technology of this whole thing. So people have lots of choices now, don't they? And I'm sure you don't help them make the choice, but you give them the opportunity to understand all the choices.
Correct. It's great when breast cancer is found early enough that a woman has many options as far as how it's treated. And I know sometimes all the options can be overwhelming, but I feel my role in that scenario is to provide information and educate patients about what are all the safe options. And so sometimes it may be you can have a choice between a lumpectomy and a mastectomy, and for the vast majority of women, the outcome of a lumpectomy versus a mastectomy is going to be the same. You don't necessarily live longer by choosing one surgery over the other. And that's what I feel my role is to educate them about their safe choices. And then sometimes people need to take a day or two or a week to really think and make a decision about which surgery is going to be the best one for them. And I will frankly tell my patients that, if I think that you're making a decision that's going to be harmful, that's going to lead you to have a poor outcome, I will say, I don't think that's the best choice. But when it's safe to decide between one option and another, I will always say this is your decision to make, because both of them are going to offer you the same odds of putting this behind you.
Good advice. I think the one thing that I have heard from people is, some doctors know how to tell their patient they have cancer. Now, by the time you get someone, they already know they have cancer. Isn't that true?
Usually, but sometimes that's not the case. Sometimes we may see someone with abnormal imaging, and we're the one ordering the biopsy, and we have to give the diagnosis. And it's never easy. It's not something that I think you ever really feel completely comfortable with doing. But my approach is I try to get a sense of what my patient needs to help get them through. I'm here for them. So some of my patients want a lot of numbers, want a lot of statistics, and I'll share that with them, and that's what they need to process the information. And other patients, they want me to give them a hug. And
right.
That's what they need, Yeah. And so my approach is one that's pretty tailored to the individual patient. What do I need to give you to help you become a survivor?
And so you went into this particular field for what reason?
Well, when I was doing my residency in New York, we saw a lot of women, unfortunately at the time, with a lot of advanced breast cancer. And I remember some of the ladies would say, no, I do not want to have a mastectomy. I'm not going to give up my breast. And these were situations where they didn't have a choice, meaning things were at such a state that saving their breast wasn't an option. And I felt that for some of those patients, maybe because I was a woman, I could say, really, we can't do this. This isn't safe. And I felt that I could make a difference for some of my patients, that I could connect with them and a level that they could understand that this is not an easy choice, and we understand that, but it really is the best choice for you at this time. So I felt that I could still be a surgeon, which is what I had trained to do, but I could use my bedside manner and really make a difference with my bedside manner. So both of those things really helped me to say, I think that there's good that I could do in this field.
That's a great answer, because it is true. There are people who are excellent physicians and surgeons and don't have bedside manner. And I heard about that recently from someone who actually was talking to her doctor over the phone, and he told her over the phone that she had breast cancer. And I don't think that that's good. Do you?
No, I, as a general rule, try to avoid that at all costs. And it's hard because occasionally I may have a patient who they want the result right now. I have to get the results right absolutely now. And I'll say, no, I really want you to come in to discuss what the results are. So I prefer to not do it that way. Have there been situations where, it is the best option, I felt? Recently I was going out of town for a meeting, and I knew I was going to be away for 5 days. And the results came back at 5 o'clock in the evening. And I had to make a judgment call. Do I let this patient sit and wonder and wait? Or do the best I can and try to convey over the phone what's happening, answer as many questions as possible, be as compassionate as I can, so at least they know what's happening. And then, we address the issue as soon as I get back. So as a general rule, I prefer to do it face-to-face. Are there exceptions to the rule? Yes. Are there some patients that I do think that for that individual, it is better for them to know right away, even if it means on a Saturday, that can happen too.
Yeah, I understand that, and I think that is the right decision, because that's always the hardest part, that someone has to wait. I mean, it's hard to live that way, to wait when,
right.
So that's a good thing too. And then you follow up with it. So as a breast surgeon, tell us about the reconstruction, because I now read a lot of the celebrities, they look great, and they talk about having total reconstruction.
Correct. Things have come a long way. For selected patients now, we can actually save the nipple and the areola. It used to be standard that had to be removed when someone was having a mastectomy. So that is a great advance. There are some women that we can go what we call directly to implants. So some women, we used to say, okay, we need to put a tissue expander in, kind of like an empty water balloon, that the plastic surgeon would have to gradually stretch the skin and stretch the muscle and by putting fluid into the water balloon and then taking it out several months later and then putting a better shaped implant in. And that's one type of reconstruction. But sometimes, let's say somebody says, I just want to be a B cup. That's where I'm most comfortable. They can directly put the implant in without going through the tissue expander phase. So for those patients, they go into the operating room, a mastectomy is performed, their nipple is spared, then implant is placed, and they come out of surgery and they're done. And I think that's, for the right patient, that is a great option. There are some patients that say, I really don't want an implant, and the plastic surgeon may say, okay, if we're not going to go the implant route, then maybe we could take some of the fatty tissue from your abdomen and use that to rebuild your breast. And sometimes at some hospitals that can be done at the time of the mastectomy, or sometimes we may say, we think you're going to need chemotherapy, radiation therapy. There's a lot of other treatment necessary for your cancer. We think that should be the priority. We can always come back later and rebuild your breast to a manner that looks very acceptable to most people.
I'm so glad you're on the show because I'm going to say I've saved something for you. I read, and I think it was in the Miami Herald, I think it was the New York Times, that there was a man who was famous for tattooing the nipples on women. Oh, you know about this, I guess, because you would. And it's because nipples are hard to construct correctly?
Mm-hmm. Correct. Because it's a balancing act. A lot of times women, we don't want to have too much nipple projection. Then we have to start putting padding in our bra so that it doesn't show through our clothing. Most women don't want their nipples to show through their clothing, so you don't want that much projection. But then the other end of the spectrum is you don't want to go through a surgery to give the look of a nipple, but then have it so flat that it still really doesn't give you that look of a nipple. So what's becoming pretty popular are tattoo artists who are skilled at doing what's called 3D tattooing. So they can shade the nipple areola area, do certain color variations that when you look at it, you say, I see a nipple. It's a little bit of an optical illusion. It does have the appearance of a nipple, but the skin remains flat. And I think that's a nice balance where if you're looking at someone, you see the nipple areola, it looks like there's one there, but the woman also doesn't have to worry, is there projection that's showing through my clothing? So that is one of the appeals of the tattoo, as opposed to the procedure where sometimes they reconfigure some of the skin in the area to give a little bit of a bump so that you have the appearance of a nipple there. But unlike our natural nipple that can sometimes be erect and flat, it goes back and forth. When they surgically place the nipple, it stays in that position. I
see. And then just working through with tattoos, I once saw I don't know what, it was also either a magazine or something. It must have been a magazine because it was color, where a woman had she had a mastectomy, and then she had her whole body in the top, where her breast would be in that part, all tattooed. It was gorgeous. And so she could just show it, just wear a blouse open and show it, and there's nothing there. It's just beauty. Have you ever seen anyone that's done that?
I have seen some of my patients who have gotten tattoos over their mastectomy site, and I think that it's great. I think a lot of times we have to start to define beauty for ourselves. And, what do we think is, as an individual, what do we think is we're going to wake up in the morning and say, this is the right decision for me, and own that. And for some women, it's getting an elaborate tattoo, and I think it's gorgeous. If that is going to give you that feeling when you wake up in the morning and you say, I am beautiful and I've made good decisions for myself, then I think that's the right way to go.
Dr. Cassan Blake, you are a marvelous woman. I love talking to you because you're so with it. You're cool, as they say. And, of course, you are the breast surgeon there at Cleveland Clinic. Let me give people a phone number. Hopefully you don't have breast cancer, but hopefully if you have something and you need to go to a breast surgeon, you will call. And the phone number there is 800-639-DOCTOR, 639-DOCTOR. Or you can, of course, go to clevelandclinicflorida.org and /breast cancer. Breast cancer has just taken such a different route now from 20 years ago when I was doing a lot of this, and it's now, it's amazing what's happened with people who decide to have a mastectomy even when they don't have cancer yet. There are a lot of things happening with stem cells. What are you finding that's very exciting in this field?
I think it's the ongoing research to better triage who needs chemotherapy and being innovative in more targeted therapy. So for a lot of women, once we figured out what makes their cancer tick, so to speak, is it sensitive to estrogen or not, or is it HER2 positive, you get tailored therapy. And I think that's what's exciting. It's figuring out what is the biology of the cancer, and let's give you an individual treatment that focuses on what your cancer needs, so that we can stop it from growing. So for me, that's what's most exciting.
Yeah, I think that's excellent because that's what everybody wants. They want to figure that it's a one-time thing. Now, is it one time? When you go in and you clean out the nodules and you've taken everything away, can it come back?
Correct. Breast cancer can unfortunately come back. So there are two types of ways that a cancer can come back. One is what we call metastasis, where even though the cancer was moved, margins were negative, and you've gotten all the proper treatment, for whatever reason, sometimes the cancer can still spread to other organs, the bone, the liver, the lung. So that's what we call metastasis. And then there's what we call local and regional recurrence, where the cancer comes back in the breast tissue on the side of where the cancer started. Now, sometimes a patient may say, I want a mastectomy because I don't want this to ever come back, or I want both my breasts removed because I don't ever want to run the risk of developing cancer in my other breast in the future. Unfortunately, even a mastectomy does not make that risk zero of local recurrence. Nothing can make the risk zero. A mastectomy can lower the risk as much as humanly possible, but the breast is different than the kidney or the heart or the lung, where you say, okay, if I'm going to just, if I just clamp this artery, if I stop the blood supply and I cut the artery, I can just remove all of that organ. I could, just like, we can do a kidney transplant because it's possible to remove all of the organ and donate to someone else. The breast isn't that kind of organ, so to speak. The breast goes right up to the skin, and we can't remove all the skin around the breast. It's just not something that we can do and still, close the area. So a mastectomy can lower the risk as much as humanly possible, but doesn't make it zero.
Yep. And so one thing that I just hope people will do is stop smoking. And I know all doctors that come on my show talk about that, and yet sometimes people get feeling pretty, I don't know what the word is, so they think, oh, well, I escaped it, so I can now go back to smoking. It's just horrible. And I have so many friends now that have lung cancer, and of course, I don't even want to say, well, were you smoking?
Right.
But that's a pretty dangerous thing to do, isn't it?
It is. There is an association with breast cancer and smoking. It's not a strong association, but it is there. Cigarette smoking actually also impacts sometimes the kind of reconstruction a plastic surgeon can do.
Really?
Because cigarette smoking affects your blood vessels. So because it affects the blood vessels, sometimes a plastic surgeon may say, your tissue isn't healthy enough for us to do a certain kind of reconstruction right now.
That's a good point to bring up. Okay, everybody. So please, 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 don't even wait till you get breast cancer or lung cancer. Just stop smoking now. I think it's a good thing to talk about when you say treatment plans and you have certain ideas, but the difference in radiation and chemotherapy, we hear this so much. People say, oh, I'll do radiation, but I'm not going to do chemotherapy because I just don't want that. It's going to make my hair fall out. It's going to do all terrible things. I'm going to get neuropathy. How do you respond to all this, and what is real?
So they have two different purposes. And I think, one of the things I want more people to be aware of is that what takes someone's life from breast cancer is when the disease spreads and when it becomes metastatic. So our surgery tries to stop it from doing whatever it has been doing until we get to surgery. Radiation helps to sterilize that part of the body where the cancer started, so that hopefully it doesn't come back in that area where it started. Chemotherapy, however, is the treatment that addresses disease or the risk of disease spread. Because chemotherapy goes in your veins, and because it goes in your veins, it goes throughout the body. So if you think of it like this, that if there is a cell that is floating around that broke off from the main tumor before we got to go to surgery, the chemotherapy hopefully will address that. The radiation can't, because the radiation is focused to that part of the body where the cancer started. So they have two different roles, and that's why when chemotherapy is recommended, it's so important, because that is really the strong arm of preventing it from going elsewhere.
I see. So, big decisions to make, and of course there are so many people now who are on the internet reading about every possible anti-aging deal and what they can do and what should they do. It's become where it used to be you go to the doctor tells you what the program is, and then you follow it. But now, so much confusion.
Mm-hmm.
So they come there as educated patients, right? But maybe it's not the right education, and you have to figure it all out. And of course, Cleveland Clinic is one of the top hospitals in the world. So where some people live in a small community, they'll say, oh, I'm going to fly to so-and-so up in Boston or go there. Now they can go to Cleveland Clinic.
Correct.
Yeah, when it's interesting now. Of course, you're also moving all around. I know there's a Plantation Cleveland Clinic, and there's one up in West Palm Beach. It's a larger one.
Right. There's one in Parkland,
right.
Exactly, and in West Palm Beach and in Palm Beach Gardens.
But when serious things have to be done, don't they have to come down to the Cleveland Clinic in Weston?
Cleveland Clinic Weston is where we have our operating rooms. So, if somebody needs surgery, and it does need to be done at this point at the Cleveland Clinic in Weston. Most imaging can be performed in our West Palm Beach site. However, there's certain imaging, for example, a PET scan that would need to be done at the Weston facility. So a lot can be done at our outreach or our offices in Parkland and in West Palm Beach, but there are some things that we still have to have patients come down to Weston to have done.
Right, and I always have my colonoscopy down there in Weston, actually.
Oh, okay.
I just feel comfortable doing that and not have to worry about it. And actually, Weston's a beautiful place. You go have lunch and get what you have to get done, and it's a great place. I just want everyone to know my guest is Dr. Cassan Blake. She is she's of course an MD, and she specializes in breast surgery. What else? Is it just only breast surgery? I mean, you do reconstruction. What else do you do?
No. The plastic surgeon does reconstruction. The surgeries I perform are to either treat a breast cancer, lumpectomy, mastectomy, to assess the lymph nodes. Sometimes it's a lymph node biopsy or removal of the lymph nodes in the region that drain from the breast and the underarm. But also a lot of procedures revolve around abnormal needle biopsies. So the radiologist may see something, they may do a needle biopsy, and there are things that can come up in the breast that are not cancer, but we recommend that they're removed through a small surgical procedure because of the company it keeps. There could be cancer cells in a nearby vicinity. So there are a handful of those findings that can come back on a needle biopsy that are frequently sent to the breast surgeon to determine does this need to be removed or not. The other role we play is, in risk assessment, determining if somebody is at very high risk for cancer. And if somebody's at very high risk for cancer, we may say, okay, you should have a mammogram and a breast MRI, alternating to keep a close eye on things. So, it does involve more than just the surgery. It's the follow-up and management of high-risk patients as well. I
see. And have you ever told anyone that they should have a mastectomy when they don't have cancer yet, but that they're carrying that gene?
So in that scenario, it's a discussion. Because they don't have cancer, we could say, look, your odds of developing breast cancer by the time you're 80, maybe 60 to 80%. So this deserves real consideration. But that is ultimately, as with anything, the patient's choice. So when somebody has a mutation, options include the surgery, but it also includes high-risk follow-up, where they're getting an alternating mammogram and MRI, or it could also include high-risk follow-up and taking medication to lower their breast cancer risk. So those are all options, but the one that would offer the greatest amount of risk reduction would be to perform a mastectomy.
Mm-hmm. Oh, lots to talk about, isn't it? And it's, of course, we have now so much prostate cancer going on, and for a man, that's probably the same. He has the same trepidation and worry as a woman has with breast cancer.
I think that's a fair statement, yes.
And so as we started off the show, yes, it is October, and yes, it is breast cancer awareness, but let's be aware every single month or every single day about if you feel anything that's a little unusual. And of course, we do have those tests of ourselves. We're supposed to, what do we call that? A self-breast exam. Is there any hints you can give us on that?
I think it's about becoming comfortable and aware of what is normal for you. I occasionally have a patient who'll say, I don't want to check my breast because I feel lumps everywhere. And I'll say, okay, a lot of women have lumps everywhere, but I want you to get to know your lumps so that if something changes, you can ring the alarm. That's the purpose of a self-breast exam. It's not to just confirm there's nothing there. It's to confirm also after you've seen your doctor, go home that evening and say, okay, the doctor examined me today. They didn't feel anything. Let me see what my normal is like. And then use that as your baseline every month to say, okay, I know that I'm thicker in this part of the breast, and that's how it's been forever, and that's my normal, and my doctor says that that's okay. So it's getting used to what's normal for you.
And what causes the fibroids in your breast?
We don't know really what causes the fibrocystic breast change or breast disease, or there are other benign findings, fibroadenomas. We don't know what really causes them, but the good news is that they're not really associated with breast cancer risk. It's more of a nuisance because it makes your breast feel lumpy, bumpy, and it can sometimes make a lot of cysts that can show up on sometimes breast imaging, but it doesn't increase your risk of breast cancer.
I see. So that's but you do need to know what your breast is like, and as you said, if you know it is bumpy and lumpy, then you need to know what the particular lumps and bumps are. But it's very important also to have that mammogram every single month, right? We don't want to have it more than once a year, do we?
Unless there's something that the radiologist says, I don't think this is anything, but I want to watch it in 6 months. When a radiologist says that, it really isn't a reason for alarm, because the odds of that being a cancer is only about 1%, and that's why they don't want to do a biopsy, because they're pretty confident. They're 99% sure that this is not cancer, but I just want to check it again in 6 months just to be sure that everything is okay. So that isn't really something that women need to worry about when the radiologist says, let's check it again in 6 months. You just need to make sure you do get the repeat imaging in 6 months.
Right.
But outside of that, you should get a mammogram once a year after the age of 40.
Well, Dr. Blake, you've just been as wonderful and as electrifying as you have been before. And we're so excited that you took the time to do this. And I know your patients must love you, and you do such good work. And thank you very much for taking the time.
Thank you so much. I enjoyed talking to you today.
All right. Goodbye.
Bye-bye. Take care.